All right, let's go ahead and start. As you've heard over the last couple or day and a half, the center of this organization is around patients, patient voices, caregiver voices, and how it is that we can understand how they feel about this disease, how they think we ought to address this disease, everywhere from what kinds of products and targets should be done and made by industry, but also how regulators ought to assess those drugs and how Medicare ought to reimburse them. So we have launched what you're about to hear about AD PACE, Alzheimer's disease, patient and caregiver engagement. And one of the leaders in this, one of the advocates for it, and one of the thought leaders for all of this area, and one of the true champions in this area is our next moderator, Ivana Rubino, Global Head of Medical, Alzheimer's disease from Biogen. She's long been involved in this field, and she has been an articulate leader and, as I say, a true champion for patients. And Biogen has been a significant lead investor. But this particular initiative actually is managed and run by patients and caregivers, but with the deep understanding that the pharmaceutical industry can bring to our inquiries. So, Ivana, thank you for what you do, and thank you for moderating this panel.
Thank you, George, and thank you for inviting me to moderate what I think it's going to be a very interesting 1 hour. We have on stage a fantastic panel. First of all, I would like to introduce you to Jerry Taylor, who is a clinical trial participant and a person living with Alzheimer's. We have Brett Hauber from RTI Solution, Holly Krasa from Otsuka, Ian Kramer from Lead Coalition, and last but not least, Marta Villanigro Santiago, and I'm very happy to pronounce her name well, right? Who is going to share with us her experience caring for her mom. But I will let my panelists tell you more about themselves. Starting with you, Jerry. Do you mind sharing something?
No, I don't mind at all. Oh, need the mic. I'm Jerry Taylor. I'm living with Alzheimer's diagnosed about 6 years ago. But obviously probably slightly symptomatic before that. I worked for 45 years in healthcare. I'm a registered nurse with an MPH and in biostatistics, so I have done research as well.
Thank you. Brett?
I'm Brett Hauber. I lead a group at RTI Health Solutions where we essentially develop surveys to elicit from patients what matters most, and what patients are willing to trade off in the decisions they're willing to make when they're looking at treatments that matter to them. And I was just thinking today, as I was hearing others speak, I remember when I started in this field, nobody cared what I did. I was kind of off in a corner, and now finally the patient voice matters, and we have panels like this one, and what I say, people actually are curious to hear me, so it's kind of nice to be in a new position.
Hi, I'm Holly Krasa. I head up the health outcomes research teams at Otsuka Pharmaceuticals, which basically means we look at disease burden and impacts of different diseases on those living with Alzheimer's and other diseases, as well as those around them, and how these diseases impact society.
Thank you.
Good afternoon. I'm Ian Kramer, Executive Director of the Lead Coalition. George has been good enough to tell you a bit about the coalition earlier today, so I won't repeat that. But I'll echo maybe some of what Brett said. I've been doing Alzheimer's and dementia public policy for 22 years, and when I started, most people didn't know what I did, didn't understand why it mattered, and didn't much care, and it is a fabulous change over those 22 years to be at a place like this today where everyone gets it, cares, and wants to be part of creating change. Day-to-day lived experience of dementia, but also searching for that ultimate cure along the way.
Yes, we all know now it's Marta Villanigro Santiago, and I've been a caregiver for my mom for 5 years. And while her doctor did not provide any information to her or to my sister and I about what was to come, my sister and I decided to take steps, or begin taking steps 5 years ago, to make her have a quality of life. Sadly, we quickly found that the lack of care, the lack of information for Latinos.
Thank you. Before going into the questions for our panelists, let's say why it's so important to have patient-centered research and later on being able to really consider the voice and hear the voice of our patients and our caregivers. Certainly, this is important now as we are trying to fight the disease, but in the near future, hopefully, we will have therapies approved. And to really understand the effectiveness of these drugs in the real world, it will even be more important for us to really listen to the people living with the disease. And I think today we have a panel, as you have heard, which is really representative of some of the key stakeholders who can really enable us to understand how and why to hear the voice of the patients and the caregivers. But the first question is for you, Brett, our technical expert on the panel. Can you tell us a little bit more what patient-focused drug development is and why it's so important in the Alzheimer's research space to start being more patient-centered?
So patient-focused drug development is a buzzword that you'll hear a lot of. And in PDUFA 5, FDA was required to do these patient-focused drug development meetings. And what it really means is actually getting the patient voice into decisions about the development and approval and reimbursement of treatments. Which, that sounds really like it shouldn't be novel, but it really is. Up until very recently, the idea was you discovered a compound, you saw if it worked, and then you tried to market it. No offense, Holly, you marketed the hell out of it and got what you could. But I mean, and that's how the system worked, but the patient input to that was never front and center. It was always present, but it was never front and center. And the idea is to put the patient needs, fulfilling the patient needs, front and center, and ensuring that not only when you develop products you have the patient in mind, but also when you do have a product that you can demonstrate the value of that product to patients, to those who may not see that value. So it kind of goes both early and later in the drug development cycle. It's important to have the patient voice throughout.
Thank you, Brett. So more than 1 year ago, we all received an email from George, Mariel, and Deborah asking us whether we wanted to be part of an initiative called AD-PACE. And now I have to read you what it stands for. The Alzheimer's Disease Patient and Caregiver Engagement. Biogen, Otsuka, Lilly, Lundbeck, Lead Coalition, and Instead were, together with Us Against Alzheimer's, really part of this multi-stakeholder initiative. And now I have a question for Holly. So can you tell us more why Otsuka decided to tackle this issue and be part of this pre-competitive initiative, and how the results we are getting from this initiative will help you with your work in Alzheimer's?
Sure. As Brett mentioned, the tide sort of changed, and actually it's really thanks to you all that Congress passed several laws that required the voice of patients and those around them to be heard and be put at the center of everything. And those of us that have been researching in this area, yeah, we were behind the scenes for a very long time, listening to what patients needed, but it's not necessarily something that was part of a regulatory decision process in a rigorous way. Each of you has independent stories and perspectives and cultural backgrounds on how Alzheimer's disease impacts you. But pulling that all together in a way that can be believed as representative for the nation or individuals like you or different characteristics was really only done behind the scenes for different purposes. So that new legislation really brings to the forefront what has been going on for a while, but brings that voice forward in a very strong way, which is very, very critical for what we do inside of industry, whether it's from creating treatments for patients for what matters to them, and not maybe what matters to their doctor, but what matters most to the patient that they would like to improve upon. And also translating those things that maybe are a little bit more technical from a clinical perspective to those that are living with disease and their families, and to payers and the healthcare system. So we joined this initiative really to grab the perspectives of everyone on the panel, led by patients and caregivers. This is a very important perspective to have, and being able to collaborate across industry and with other stakeholders from our government who are also advising this initiative allows us to have a much broader perspective and get rid of our own personal biases so that we can have a greater impact.
Thank you, Ollie. Jerry, why is this effort important for you?
Excuse me for reading, but I could go off script very easily. So in all of our interests. In my experience, there are so many varying individuals in which Alzheimer's plays out its sinister game. With any challenging puzzle or game, we all approach the solution differently. Sharing many different approaches and priorities with others may facilitate our own path to our answers to the puzzle. Any ordinary daily task or medicine. In addition, I find kinship in connecting with others on the same path. I gain ideas and strategies for living and sharing with others, but mostly I feel validated, like a tourist looking at the pyramids in awe together and saying, it's really there. Lastly, because of the long history of Alzheimer's disease not being recognized until the late stage, there is an expectation that we with the disease cannot speak for ourselves. AD-PACE and the A-List are helping to break down this misconception. It is extremely important that the voices to be recognized to give us this therapeutic advantage to our better health.
Thank you, Jerry. I would love to now ask something to Marta, because Marta, as a person living with Alzheimer's, with your mother, your experience with your mother, what do you think your insights can help us with as we develop drugs for Alzheimer's disease?
Well, I think, as Jerry has pointed out, while the patient is in the best position, we know sadly at some point, or even on an off day, as we say, and we could all have off days, and we have people who speak on our behalf. Well, that's what we do. And we can certainly add to this conversation. We see it firsthand, as well as the patient, but there comes a time where we have to step in completely. So as my sister and I did, because actually in my mother's case, I'd say about 2 years before we got the diagnosis, and she's been living with it for 5 years, or we've been living with it for 5 years, and about 2 years before we started to see changes that maybe the person has not become aware of, or no one else certainly has become aware of them, so why do anything about it? But my mother was living alone at the time. I should add, in New York City, and my sister and I are living here. Born and bred in New York. And so in that environment, we kept a close eye on her, because that's just the way Latinos are, for those of us who don't know. And so, but I noticed when I went, spoiled food in the refrigerator, unopened medicine in the flower pots. And she was no longer watching her favorite baseball. No interest in it whatsoever. And so as time passed, more changes occur, and she became very comfortable relying on my sister to be her nurse, her caregiver, obviously, her friend, and most importantly, her advocate. She is in a nearby nursing home, and I see her several times a week, and we take her out when she can make it. But she will regularly say when something is not right or she doesn't recognize what's going on, in her broken English, "That's my daughter." They swear that she's bilingual, but she's really not. But amazing that, as Jerry added to the conversation yesterday, you learn a great the person is a different person, and we see that as caregivers. And so they can't be ignored. And together with the patients and everybody else, we can add a lot to the conversation.
Thank you, Martha. And I think it's very clear, looking just at this wall behind the panelists, that we all want to be the change. And the next question is for Ian. How do you think that patient centricity and our efforts in patient-focused clinical research may actually drive the changes at the regulatory level, policymaker level, and also from a payer perspective?
Well, so it's a great question, and I think it feeds well into the broader dialogue of these 2 days. If we think of this through both a technical kind of regulatory and payer pathway lens, but also the lens that George suggested yesterday as a social justice question, more and more government is understanding that out of the person-centered movement in care, there has grown this, what we euphemistically call patient-centered view to the drug discovery and approval process. But I think they have to be intimately linked. So in many ways, it feels, I think, day to day that it's harder and harder for many of us to influence decisions of government, particularly as individuals. But with a collective voice, interestingly, this is one of the few areas where government seems to be anxious, not just willing to be more and more responsive to collective information that's scientifically valid, back to Brett's point. And the AD PACE project is an opportunity to apply that kind of scientific rigor to aggregated information. And that aggregated information, if you trace it back, is exactly where we all want this to begin and end, and that is the needs of the individual. But it's taking those needs, those perspectives, those wants, those fundamental elements of human dignity and putting it into a formula where government can accept that information and rely on it, and to Holly's point, generalize it across a wider population. So there's this interesting little hiccup in the system called the FDA, Food and Drug Administration. FDA does amazing work. They are deeply committed to the neuroscience area and to Alzheimer's and dementia in particular. So don't take the hiccup as criticism. They are actually handcuffed in a really important way, but one where we can help them. So FDA's responsibility is to determine whether a medical product, a drug, a therapy, a device is safe and effective. And that's it. They're not allowed to judge the merit of a product in terms of cost or savings to the system, or even a lot of other elements that many of us would think would intrinsically be part of the dialogue. But all the other parts of the drug discovery ecosystem, to use an overly fancy term, get to consider all that other stuff. So let's take the example of caregiver preference and need and benefit from a particular therapy. FDA is not allowed to consider whether Martha would benefit from her mother receiving a particular drug. They can only, and I actually think this is ethically the right place to be, FDA can only consider safety and efficacy for Martha's mother regarding whether Martha's mother will be allowed to and encouraged to take a particular pharmaceutical intervention or other approved therapy. Martha's benefit is really important to the rest of the system. So you skip the FDA hiccup in taking into account Martha's point of view and Martha's needs and Martha's values. And so it's not only Martha as an informant, an evidence informant about what is good, needed, beneficial, harmful for Martha's mother. It's also throughout the rest of the system, except for this little blip at FDA, it's also what's helpful to Martha. And so let me just wrap it up with a practical element. Suppose that the drug is wonderfully helpful to Martha's mother, but not very helpful to Martha. Maybe makes Martha's life harder. FDA is interested in knowing that. They just can't make a regulatory decision based on that. But those that do drug discovery certainly need to know that. And those that sell the product certainly need to know it because, and I think we've all been in this situation, our hearts are in the right place. We want to benefit the person for whom we offer care. But if it makes our life harder, there are going to be times when we don't do everything we ought to or hope to in terms of helping our loved one adhere to the drug regimen. And that's, we're going to let ourselves down, we're going to let our loved one down if we don't also see the benefit for ourselves. That's the practical reality And the entire drug development ecosystem needs that information, even though, again, there is this odd little hiccup in the system where FDA uniquely cannot consider it.
By now, I hope you all see the value of why we need to do that. But now, let's understand how we can do that. And I think, Brett, it's for you the question now. Can you tell us more how we can do that? We have heard during the day about AD-PACE, the What Matter Most study. Can you tell us more about how you are conducting that, which challenges you're facing, and also your first observations?
Sure. Before I dive into the What Matters Most study, I want to feed off of something that Ian just said. It is absolutely true that FDA's responsibility is to determine the efficacy and safety from the patient's point of view. And that's I agree with Ian that is ethically appropriate. But what is happening with patient-focused drug development is that we are beginning to see FDA take the patient's voice into account in making those decisions, because FDA is faced with all of this efficacy and safety data, and someone has to decide, do the benefits outweigh the risks? And FDA is open to hearing from patients, do they think that the benefits outweigh the risks? So there is the role for the patient voice. Given all of the challenges that we have in Alzheimer's disease and dementias, there is a role for the patient voice in that type of decision, as well as all of the other decisions that Ian referenced. So to try and get to that, we've initiated through AD-PACE the What Matters Most study. So the first step is to determine what matters. So what we have done is designed a study, and this is not going to answer every question everywhere for everyone, but we've started down what I think is a good path. First, we have to identify what matters. So we are just now concluding a series of systematic qualitative interviews with people across the Alzheimer's spectrum, starting with those who have AD pathology but no symptoms, all the way to talking with the care partners of those with severe manifestations of Alzheimer's disease. We've grouped these people into 5 buckets for convenience, and we are now concluding those, and I'm going to give you very, 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 very squishy results because we haven't really done anything with them yet since we're just concluding. Where that will lead to, in addition to the insights that we get from those qualitative interviews, we're going to actually develop a survey to quantify how important certain outcomes are to people with Alzheimer's disease, and which of those outcomes then are most important, so that we can say, if you're developing a drug, and that drug can do this thing, whatever it is that's most important to patients, then you've done a good thing. And if you can't do that, maybe you've missed the mark a little bit. So that's the ultimate goal. The other goal is, if we can do that, we can say, look, payers and people who reimburse, these people are delivering value because they are delivering what matters to patients. And this isn't only limited to drugs. It could also be any kind of care program or technology that can improve the lives of people with Alzheimer's disease. So if you can't tell, we're a little bit grandiose. We've got some really big hopes for this thing. But we've got to take it one step at a time, because at the end, what we have to do is deliver something that is scientifically credible and rigorous, because we have to demonstrate that what we are talking about really does matter, and we've got the proof. So that's our goal. So we're finishing up these qualitative interviews now. We're then going to turn this into a quantitative survey, where we're actually going to get from those same 5 groups of people, from those without symptoms to those with more severe disease, we'll be able to quantify, we hope, what matters and what matters most. So from the qualitative phase, this is the squishy stuff that I promised. We have not begun yet to analyze the transcripts. But when we start asking what matters from patients, and I'm only looking at the early groups here, because we kind of have to switch gears once we get into the moderate and severe stages in how we look at the data. So we've kind of punted on that, not because we're lazy, just in the interest of time. But what we've done so far is taken somewhat of a close look at what we see in those without symptoms, those with mild cognitive impairment, and those with mild dementia. And what we see is that the people with no symptoms don't complain about symptoms, but boy, do they worry. And they worry about the future. And then those who start having symptoms, they've talked to us about relying on reminders and lists. And more than they did before. And that's kind of the key, because we see changes here. That's what really matters, are the changes from what happened before. And the reminders and lists themselves, I've got to make them just because I'm no longer a young kid anymore. But that reliance on them, there's something fundamentally different that changes there, where they're not just a helpful tool, they become a necessity. And that's an indication. And then we see, when we start getting into the people in what we're calling group 3, which is the mild Alzheimer's disease, we're finding that it becomes a lifeline. Those lists really become a lifeline, and communication becomes an issue. And people become insecure because they can't find the right words. And then what happens, and this is what none of the existing tools actually measure, and another reason, a good example of why we think this is important. When people can't find the right words, they engage less in conversation, and they begin to withdraw socially. That's a real outcome that we begin to see in people with dementia and Alzheimer's disease that is not captured in the cognitive assessments. As good as those assessments are, I don't want to say that they're not good, but they don't capture these things that matter, and that's our hope here. So when we start saying to people, if we could develop the treatment, what would you want? Interestingly, everybody says a cure. That's not surprising. But knowing that that's not likely to happen, what is it that we can impact in your daily lives, if we could, that would make your life better and have the biggest impact on your life? And it ties right to the problems that people tell us that they have. It's, if I didn't have to rely on lists and I could go through my day and function normally without having to remember that I've forgotten, that matters. And if I can find the right words or have the tools where I can engage in a conversation with my family. One of the most compelling stories I heard recently was talking with a guy who was saying family dinners are the big thing, and he can't participate anymore. And we need to be able to capture those types of things, because those are the real impacts. And this is just a snapshot of what we hope we'll be able to find and quantify in this study. Then our goal with this, as I said before, we're going to conquer the world with this thing because this is the greatest study ever. We're hopeful. We are really hopeful about what we can do here, because we do think with this type of information, we can demonstrate the value of drugs, not only to FDA by saying these things are affected by the drugs and these things are that matter to people, but also to the payers and to other decision makers and people who are developing the programs, to find out if we can nail this and we can fix these things, then we've got something real here. And that's what we're hoping these tools will be able to demonstrate. Sorry, that was long-winded, but I feel a little passionate.
So, while we are all eagerly waiting for the final results, I want to ask Holly to share with us what is the plan once you get the results? How will Otsuka and, in your opinion, the other companies use this data to continue the research?
Sure. As Brett said, there's a lot of hope for this information, but a lot of the tools we have right now are asking things that are very specific to certain people's perspectives. And we really hope out of this initiative we'll be able to get something that is much more common to everyone's experiences. You'll see Brett just showed you very general phrases that you could map, say the statistical people on this side of the panel might be very upset about losing our numbers, where the lawyers on this half of the panel might have it worked out that way, we didn't plan it, might be more upset about losing their words. And how that maps to one common concept, it's really our passion for life, and the thing that gets us up in the morning is what we would be losing. And how we map that into a common tool is really a great benefit for all of us within the industry and within all the service, those that develop services and technologies, to help wrap around this community and see how we can support what's going on and delay what's going on over time. So it's really that end toolkit or understanding of the commonalities that we have and the words that we should use to create those commonalities that will really benefit us long term.
Thank you, Ollie. So as part of ADPACE, we have the study that Ollie and Brett share with you in terms of details and the purpose. But there is also this online community called A-List, which offers the opportunity to the people living with Alzheimer or at risk or concern or who have been experiencing Alzheimer in their family to really share insights and to engage, but also to be involved and have their voice heard via different surveys and so on. So I have a question for you, Jerry, as an active member of the A-List. Can you tell us more about your experience with A-List?
One thing I really like about the A-List is that I can be heard and share my Alzheimer's experience from my living room. In contrast to helping finding a cure for the disease. And I travel from New York to New Haven once a month for my drug infusion for the clinical trial that I am participating on. The A-List surveys are short, the questions are easy to understand, which is important for the person living with the disease, and about issues that we are concerned about. My husband and I were able to help structure the survey of the clinical trials earlier this year. This survey helped provide valuable information on the clinical trial enrollment and the barriers to participation. So we have firsthand experience in understanding the value they provide. For me, one of the most encouraging things about participating in the A-List survey is that you not only get to make your voice heard, you also see the results of the survey. I believe this is rather unique among surveys I've participated in. It encourages me to take the survey because I want to know how other people are living with the disease and their care partners and how their care partners feel about the same issues. It allows us to speak for ourselves.
Thank you, Jerry. Marta, why do you think it's important for us to hear different patient preferences, to be heterogeneous as we speak about that?
Well, I think I'd echo actually some of the things that Jerry added. But first I'd begin with, you can't ignore the numbers. As over the years in my legal, under wearing my legal hat, accountants have told me numbers don't lie. When older Latinos and African Americans are more at risk for getting Alzheimer's, and get statistics like African Americans are twice as likely and Latinos are 1.5 times as likely, you can't ignore those numbers. And the A-List is taking those diverse communities into account when we're looking for the best way towards a cure or the prevention. And researchers, medical professionals will tell you, we don't know why this is. That, and I'll just speak from my own Latino background, and that's scary, that they're just, okay, well, we really don't know why that is. Next question. And so that's troublesome because we can't ignore that reality. We don't want to ignore the numbers, the total numbers of Alzheimer's. Well, this is another big total number that we can't ignore. One, you have the patients that are living with this, and you also have the medical professionals who are coming up with nothing. So the research, the clinical trials, and this is where I have, of course, a lot, Jerry and I agree on a lot of things, is you have to make these clinical trials or studies more accessible. But accessible, when you talk about diverse communities, is no different from what she just told you. You need to get to the place where they're holding the trial. Whether I can get out of my house, am I in a wheelchair? Now I'm wearing my ADA hat. How do I get there? Whether I have Alzheimer's or not, how do I get there? I don't speak English as my first language. That's actually true for me. So how do I get involved when I know that it's to my benefit? Or, as Latinos will tell you, we care about what happens to the rest of my family. I do. My mother may have some idea of what's going on with her, but she really, but I'm concerned. So we want to participate in a clinical trial, but here's the other reality. As a discrimination professional, and now an advocate for my mother, I've also identified that Alzheimer's doesn't discriminate. I'll end it with that.
Thank you, Marta. So let's close this. I know it sounds like I am asking for so many questions to the panelists. Sorry, but we really have a big source of truth on the stage. Let's go back to the change, the concept of change. Ian, how do you think that all these efforts together, the What Matter Most study, the A-list, the overall hearing and listening to the voices of the people living with Alzheimer's, what you have defined as the basic human truth, I do think that all of this will contribute to the change as we go toward, hopefully one day, where we will be here celebrating therapies and one day cures.
Well, so I think there are a couple of elements to it, and the first is to go back to a point that Jerry made. It's one thing to be listened to, it's another to be empowered to make change happen based on what you've said. So I think thankfully, we are mostly through the severely patronizing phase of, sure, go ahead and say what you want to say, and then I'm going to do what I'm going to do anyway. I think that's not over, but we've made tremendous progress. And again, I think that began in the person-centered care movement and is now evolving nicely, not perfectly, not completely, in what we call patient-focused drug development. Parenthetically, don't love the word patient, but I'm using it here in this very medical context. Outside of the medical context, let's remember, and this goes to the point of your question, the fundamental humanity of people. We are whole human beings, whether we also happen to be in a discrete part of our lives, active patients in a clinical study, in a physician's office, et cetera. So that's the other part of this, that there is a real danger in our field, and I think we've seen this play out far too often, that we take away independence and we take away independent voice and authority and autonomy from people living with a disease that causes a set of symptoms we call dementia. We tend to take that away too soon. We do that often in our families. We certainly do it broadly in society, and for all too long it's happened in both the drug development process, but also in the regulatory process. And Brett alluded to this also, a wonderful development, thankfully not a recent one, but again, not a complete one. FDA very much, and I think very sincerely, wants to hear from and wants to act based on the expressed preferences of people living with dementia. The trick in this, and I don't have the answer for it, but I think part of what the AD PACE project and the What Matters Most study will help us get at is how far can we lean into respecting that point of view as long as possible, as completely as possible, as far into the disease process as possible. And I think of this I came from the care side of policy work for the first 15 years of my career before I did much at all on the science side in the last 6. And as a lawyer, I'm not good at anything. I just sound like I am. But Martha's great. I'm not. But one of the things that I hope I have learned over the last 22 years is some degree of humility about all the things I don't know and all the places where I really ought not be speaking for somebody else until there is conclusive evidence that they cannot speak for themselves and need me to speak for them. And it is so much better and I think safer and more ethical, and this goes to the fundamental human truth issue, to err on the side of trusting, listening, respecting, valuing, and acting on that too long rather than not long enough. If you think about if you think about everything this disease takes away from people, and there is an unending list of those things, why in God's name would we exacerbate that problem? Why wouldn't we hang on to and help those we love hang on to as much of their autonomy, their independence, their preferences, their needs as long as possible, and then work back to sort of whittle out the parts that are not, to borrow the phrase from Brett, scientifically reliable evidence. I think we can learn to do that if we are willing to learn to let go of our substituted judgment, well-intended but substituted judgment, and rely on the judgment of the person who is living the experience most directly.
Thank you, Brett. I think we're still doing right on time, right? When you ask an Italian to moderate, you never know. But this means we have some time for you if you have questions for the panel. I think there are microphones going around in the room. Yes, they are bringing it.
Hi, thank you. Ian, I'd like to talk a little bit more about a concept you brought up earlier in the discussion, and that's where some of the needs and the interests of the patient and the caregiver not only diverge, but may be opposed. What an experience for all the panelists out there, do we have a good understanding of what those are and a framework for how do we reconcile them?
Well, let me just give a quick example as top of mind for some of us. Driving. There's an old adage, I think there's some truth to it, it's not universal. Women give up driving too soon, men give up driving too late. And in a caregiving context and a living with one of these diseases context, I think there is an understandable impulse by many, not all, family caregivers to take away the keys or remove the spark plugs or whatever they think they need to do to provide more safety and reduce risk. I think most of us are aware that that loss of independence from an inability to drive, either an intellectual inability or someone's taken the keys away, a physical inability, that isolation is profound and important to a sense of self, a sense of being an adult, and access to a lot of things that are meaningful in terms of quality of life. And I remember a conversation that Jerry and I had a couple of months ago about how many, thankfully fewer and fewer clinicians are obsessed about this question of whether they can extend the life of the person living with Alzheimer's disease or another disease-causing dementia. And again, not universally, but I think Jerry was nodding along with me when we were talking about this a couple of months ago. Isn't the real question whether we can improve quality of life and sustain quality of life for as long as possible? And that may sometimes come instead of, not always at the expense of, length of life, but the real fight here is preserving independence, dignity, and happiness. And sometimes taking away the car keys is the right thing to do given the degree of risk. But again, we tend to err on the side of caution to such an extreme that we are worsening some of the quality of life aspects out of our abundance of caution. And that might not be in alignment with the wishes of the individual who has the actual disease.
Marta, please.
If I may, once a lawyer, always a lawyer. And, but now as my mother's personal lawyer, it's a matter of balance. And I don't think Ian's saying you go one way or the other. You take them all in. It's like most of us, some of us, will look at what the side effects are of a medication before they take it, we hope. My father, of course, was not willing to take Lyrica because he saw, oh, it could cause like thoughts of suicide. Anyway, but you balance. So in my mother's case, that's exactly what I do. Because as I said in the beginning, the caregiver, we are entrusted with that, or we accept it because we are looking for their quality of life. End of life, terminal illness, all that. When they tell me, my mother and my father both told me, do not put me on any artificial means. That's what that is. Quality of life. Whether you believe in it or not, but that's what we're doing. So in the Alzheimer's cases, it's the exact same thing. It's just that it's never been looked at that way, and I agree with Ian that you do not want to substitute. I try to stop myself from thinking from my mother for answering from my mother. She was trying to look up a word, and I just go, you know, W comes after T. Okay. Just takes her longer. But I let her occupy herself to do that. So it's up to that person to do that balance. It's not up to FDA or the scientist or the doctor. I've disagreed with doctors many a time. Whether it's because I'm a lawyer or just because I'm my mother's advocate, I don't know.
Thank you both. Is there any other questions for the panel?
I found it to be very enlightening. I think one of the problems that I've seen and faced, and I think, Dr. Huber, you're only if your research was done 5 years ago, we'd be so much more advanced right now, is that the FDA doesn't really take into account the quality of life from the caregiver's point of view. It only looks at mechanically what the drug or device does for the patient. And if in fact it followed your prescription, we'd have many new drugs for Alzheimer's in the market and many new devices, as opposed to a 20-year hiatus before they accept something else because their standards are set to not for the quality of life, but for a test which may be artificially created. So I give you a great deal of credit.
Well, thank you for that. I guess there are two things. I do, and I've had these conversations with people at FDA. I mean, legally, in a sense, their hands are tied, and the lawyers know this better than I do, in terms of what they are allowed to consider. But I do think one of the key things, and what gets me so excited about the work that we are doing, is that I feel like finally we are actually truly trying to capture the voice of the patient. And you know, we can capture the disruptions in life that happen later on in the course of dementia because they're more obvious. And some of the conflict that Patrick had kind of alluded to that we've seen in terms of priorities for patients and care partners in the later stages occur when the person with Alzheimer's doesn't realize that a certain thing is probably considered by some to be out of bounds. But for the care partner, it becomes a really important thing. And so we begin to see the priorities differ at some point along the continuum there. But in the earlier stages, you know, I'm just going to take the liberty here to share an anecdote. My mother has vascular dementia. And if I had known early on what the signs were, my mother was a bookkeeper her entire life, and it should have dawned on me when she couldn't balance her checkbook that something was wrong. And I didn't get it. Until much later. But you know, early on, it's those things that you see that matter, that the caregiver might see, that the person who has the disease or symptoms of the disease or may not even have symptoms yet doesn't see yet. And how do we actually detect that earlier? And how do we detect that in a way that reflects the symptoms. Because at that time when my mother couldn't balance her checkbook, I didn't think of having a cognitive assessment. It didn't occur to me. But I could have told the doctor she can't balance her checkbook, and that should have raised a red flag for somebody. So if we can develop the tools that can translate those things that we see, particularly when they're subtle and early on, into things we can measure, and we can say, something's going on here and there's a treatment that can address that, that's where I think we need to be. So I think we're headed in the right direction. We can't lament, I wish we could have done all of this years and years and years ago, but I think the timing is right now for us to be able to do this, and people are listening, and that's the big change.
Thank you. Please, there is another question here.
I just have a comment. I just want to express total gratitude for this new group, because for so many years I've been living with the dementia, and so many of my rights are taken away. I mean, I almost feel like I really don't have a say in anything, no matter where I go. And it's sad that we don't do this for any other disease but dementia, that we just basically lose our rights. And I hope, and I just love the things Ian said, because it's so true. They wanted to take my driver's license away 10 years ago. I'm still driving. I'm driving great. And they only want to do it on the side of caution, because they said, well, you may have an accident one day. Well, so's the average person have one every 5 years or something like that. So it's like, so I commend you folks, and I hope you can really bring the rights back to people like myself.
Thank you.
Started in this journey personally with my father, and it has now been my professional journey. And what I'd like to ask you collectively is, I lead a support group. I hear spouses say, I'm suicidal. I have family members come into my office and say, tell me this is going to get better. Or, I just need a minute, Marcia. And their eyes are just flooding. So at 10:30 Saturday morning, when I lead my support group, what source of strength and comfort can I offer to them and hope?
Marta?
Caregivers.
Sure.
These are the spouses. These are folks living. I manage a building in a senior living community, including a secured memory care community.
Thank you, Marta.
Well, I also participate actually in a support group, and I thought you were going in another direction. I said, no, I go to it because I find what I said to someone earlier, that this is a safe space here for all of us. I reunite with people I saw last year, and I find that, that's reassuring, and it gives you a good feeling. But when you want to hear something reassuring, one is that we do consider it a safe space when you walk in there. And we may cry because it is a safe space. Also is to really emphasize, like we do to the persons next to me when they're having that sobbing moment, is you need to take a break. So I may do my window shopping because I just had my good cry. So take a few minutes. I mean, the people around the group will tell each other, what's your plan B? You need a plan B. What happens if, and very bluntly, if you can't be there, who's going to take care of her? But you got to take care of yourself. So the best message that you can give to people that are really at the bottom that day, I think, is to reinforce and repeat over and over, whatever it is. And I think we all said is that there is no one solution. I would say there is no one solution. Like I said, I could go just window shopping and on silliness, or even buy something silly. And that'll just make me feel like, okay, My life is just as normal as those other people that are walking down the street and don't seem to have a care in the world. And that's okay. So just to take care of yourself. That is the most priceless piece that we give each other in the support group, is that. And we don't do it alone because clearly we go to a support group.
And I'll just do an unsolicited advertisement and ask Ginny Bigger to stand up at the back of the room. And she doesn't know why I'm doing this, but it's okay, Ginny. Go talk to Ginny afterward, because among other things, you can find out about the Us Against Alzheimer's Facebook community, which is how many people now, Ginny? 5,000 of your new closest friends who get it. And that's a virtual support community. Loretta Vini?
Loretta is the moderator. And so, yeah, we have a great team, but they're on Facebook. And it's closed.
Kim Campbell's blog. Kim, can you stand? I'm going to make everyone stand. All right.
As a caregiver to my husband, I know exactly what you're talking about. I've been a part of support groups, and I experienced the crushing depression and the hopelessness. And so when I joined a support group and realized everyone was just as depressed as I was, I thought, this is not healthy. And I've got to take care of myself to be the best person I can be, not only for my husband, but my children and the rest of the people in my life, and for myself. So I started a blog called careliving.org. And we don't do any sob stories because that's a given. We as caregivers get it. So we find a way to change our perspective, to find a different way to look at things. Someone said earlier today to look at the glass half full instead of half empty. And so my website is a place of hope, inspiration, information, encouragement, and spirituality. I think, faith played a really important part in my journey, and continues to encourage me now that I'm on the other side. But still, I have, what do you call it, post-traumatic stress syndrome. I have terrible nightmares. So, but being a part of a support group is a huge step, and knowing that you're not alone, other people understand. So point your people to my website. I'd love to have them in our community, and I'm happy to be a part of the Us Against Alzheimer's community as well.
Thank you.
Hi. So I wanted to touch upon what I think is another missing feedback loop for patients and for family caregivers. As an example, over the past couple of years, my father-in-law, who has Alzheimer's, at one point was on Aricept, Namenda, and the Exelon patch all at the same time, presumably under medical supervision. I don't know that for certain. But when my mother-in-law started noticing changes in the disease in him, changes in his behaviors, she called my husband, who is her son, to tell him that, which is all fine and dandy, but that sort of information really needed to go to their doctor, to researchers, to somebody who could put it to good use, except that you can't really do that because my mother-in-law didn't call her doctor because her doctor would charge her for that phone call, okay? There is no way to get important information that's happening in real time on a daily basis. Family caregivers' observations and experiences with this disease and the drugs, perhaps, that their loved ones are on, there is no way to get that feedback loop to the people who need it the most. She's welcome to call my husband at any time, but sharing that information with him is doing no good.
So Ian, maybe you can talk about that?
Yeah, so you may have a better answer in mind, Ivana, than the one I'm going to offer.
I'm just a moderator today.
I'm going to bring this back to AD PACE and the What Matters Most study. I think part of what we hope to learn in successive generations of these projects, not this first phase necessarily, where we need to be narrow and focused and do proof of concept, but as we learn how to do these statistically and scientifically valid surveys of both people living with disease and those who are in their care and support network. Part of what we want to learn are about experiences like this and how to improve the regulatory process and the payer, the private insurance, the Medicaid and Medicare payment systems to respond to that. Because you're right, those are not just problematic, they're just downright dangerous areas of entirely understandable misuse of these approved individual products being layered on each other. So FDA has, among other tools, they have something called a Sentinel process, which is to look at the ongoing safety and efficacy of drugs that have already been approved and reached market, but where we need to learn a lot more than what we learned about them in the clinical trial process. Once they're out in the general population, how do they really get used? And what is the real effect on a much, much more representative, hopefully much more representative population than was in the clinical trial process? So it's not a perfect system, but we should be so lucky as to have disease-modifying drugs for Alzheimer's disease where we can get to a Sentinel program. For the symptomatics, it's there, but it's not being fully utilized. And I think we do, Marion, you raised an excellent point. It's incumbent on us as advocates to highlight this to FDA in advance of having disease-modifying drugs while we have symptomatic therapies, and say, we need to do more of this in-market kind of analysis to look for these inadvertent but really serious areas of misuse and improve the clinical process for drugs that are valuable but can be dangerous when misused.
And also, I'm going to make a plug for the A-list here. This type of issue would not come up in the What Matters Most study just by the way the interview guide is developed. It could spontaneously, but it's unlikely to happen. But the A-list is a forum where if you're seeing something, that may be an opportunity to put the question out there to other people on the A-list, are you seeing this too, or do you encounter this? Is this a common thing? Then we start to generate the evidence that begins to say, hey, this is something that we need to all rally around together and address. So that may be the type of question where that topic could be a topic that is addressed among the A-list to be able to generate that kind of information.
And
Jerry, are you on that one? You write a lot of the questions for A-list.
Are you going to write that survey?
Is that going to make the cut?
Yeah. And just to add, you brought up two specific issues there. There's a policy issue about payment. There's an odd barrier in payment policy that Ian's going to take care of for everyone. And but then there's another issue. There's a technology opportunity for feedback loops to physicians and other things that maybe some of the technology groups in the area in the room can hear and understand that gap and maybe help fill that gap. But that's part of the beauty of getting all of these individual experiences either through the A-list or through formal study through AD-PACE and then studying it to see what those needs are. And as all of these results are being published in the A-list survey results, if you haven't joined the A-list, I'll plug for it as well, but go ahead and join because the survey results actually come back to those on the A-list. And so you're able to see that information even if it wasn't your survey. So, and that's something that everyone can use to help improve these situations, even if we can't fix a payment model issue in the interim.
Thank you. And I think while we are all working with the idea that one day there will be an armamentarium of therapies to really fight against Alzheimer's, I think we need to acknowledge that this is a unique place to be because there is so much work that's happening at all the levels and there are so many resources available to all of us. Sometimes it's just a matter of getting out, asking for the question and finding the answer in people who are going through the same experience. So I really hope that all these resources may help us navigating the next couple of years while we are working on clinical research. And then in a couple of years, we will have other issues, hopefully positive, good things. Any other questions? Yeah, Verna.
This has to do with caregivers. We started a project called I Remember Better. And we have something called Alz Chat. It's every Monday at 3 o'clock Eastern Standard Time. And it started because there was this young girl in England, and she was a teen, and she was caring for her grandmother. and her grandmother, she was helping her grandmother, but her peers at school were teasing her. And so somehow we learned about this, and we started this Alls Chat. And now we have on one group we have 7,000 followers, and another group we have 15,000. So if anybody thinks that might be helpful, we'd be happy to have you go to I Remember Better. And then another thing that a friend and I are doing in Chicago, we started helping people, caregivers we started with the Methodist Services Center. And so we do a workshop, and somebody was talking about doing silly things, so it's all about doing silly things, but we do it and show the employees what they can do for a couple of hours of how to work with people with memory impairment at their centers. I'm happy to share any of our ideas, and it's been a really wonderful project.
Thank you, Berna. Any other question for the panel? I saw a white flag in the back.
Thank you. I'm Danny Potts from Tuscaloosa, Alabama. I'm a neurologist, but I'm a neurologist who gets it, so please nobody throw vegetables at me. I get it because of a lot of reasons, but the first reason is that I was a care partner for my dad. And so this question is about stigma. First of all, thank you all for what you're saying and doing. It's very informative and helpful. But this is a question about stigma, which for me I think is always an elephant in the room. Because I think that stigma, at least in my world, affects the amount of money that goes toward research. It affects the way politicians vote on things. It affects the way neurologists don't help patients to live well with dementia. And it goes a long way to affecting a lot of the negative things that we've mentioned. One of the fascinating things that I read a few months ago was from the AMA Journal of Ethics, which was a paper that talked about a survey that was sent to people of early stage dementia who were asked what are the major factors that prevent you from living well. And they said, not the effects of the disease, but the way the medical community treats me because I have this disease. And so this made me rethink the way we do things. So the question about stigma is, what are some ways that you all have found that are important for us to maybe learn from you about how to address stigma, the most important ways to do that?
Marta or Ollie, you want to take it?
Well, I was, from a researcher perspective and to a doctor perspective, the way I've learned to alter medical perceptions on how to deal with patients is just evidence. Physicians are rightfully trained to look at the evidence that's in front of them and make evidence-based decisions. And what we're doing here is actually collecting evidence in a rigorous manner such that we can educate the physician community and the care community that is required to rely on evidence to alter their perceptions and stigma. And as you know, physicians don't go into medicine, obviously, to not care for patients and their family members and to do good work, but sometimes that vocabulary is not there. And understanding what somebody needs and what's most important to them. And that's where a lot of this research will come in to help educate that community, and not just the caregiving community or the patient community themselves or those that are living with the disease, but the medical community as well. So I think that's one great bridge. Because we're doing this in a rigorous manner, the belief of that information will be stronger and be able to be implemented. But
any?
Yeah, I'll just quickly add that I think I agree with mostly what Holly was saying, because it's about the communication. I find that there is this challenging conversation every time because I will go. I'm my father's caregiver as well. My father, I think we're headed down that road, but to get there, it's a very resistance type vocabulary. And, I'm sitting there taking copious notes because, okay, that was my legal training. So I take everything down, and I just like to remember things, and I will read them back. But the doctor is it's a personal affront to ask questions. And whether it's, I find that to be with anything, because my father doesn't have declared dementia or Alzheimer's. But I think in general, I think that's what it is, that the vocabulary is not there. And as a caregiver, I'm not hearing it. My father's not even hearing. He's not getting the look in his face. Just because I'm there doesn't mean you talk through me. Ian is still here. He's not dead. Well, sometimes. Yeah, he hasn't, yeah. But that's, so we have to, we talk about how employees, I was an employment lawyer, so we talked about, teaching employees communication skills. And that's what it is. Doctors shouldn't finish, learning hasn't stopped yet. And part of that still is just the communication speak with patients, with caregivers. But number one is the patient.
So just to briefly follow on that, for those of you that don't know this organization, I encourage you to go online and look up a group called Dementia Alliance International. It is so some recognize it. It is of, by, and for people living with dementia. And one of the central messages embedded within a human rights perspective about all forms of dementia is imploring all of us, whatever our role is, in the family, in the clinic, in research, in any other aspect of public or private life, to focus as much as we humanly can on what people living with any form of dementia can do, not ignoring what no longer can be done, but trying to emphasize ability over disability, not, again, ignoring disability. So it goes back, Patrick, to your question about the perceived conflict. And sometimes the conflict is real and it's legitimate, but I also think we sometimes overemphasize the conflict between patient and physician, between carer and patient. Again, I'm falling into that awful patient word. But 99% of the time, I think we're on the same page, both in intent and in process. It's that 1% that is incredibly messy, but if we can superimpose on that 1%, trying to resolve the 1% of legitimate differences of viewpoint and need, this emphasis on ability over disability, then maybe we get that down to 0.5%.
And if I received clear messages, now I have to almost say goodbye. But if we go back to the stigma and the communication around Alzheimer's, it's so hard to articulate that conversation, because the question will be, what shall I expect from the disease? What does it look like for me? And that's why efforts like ADPACE, because they are done in collaboration with the people who are going through the Alzheimer's journey, they will enable also better discussion around Alzheimer's for people to really understand what Alzheimer's and how to talk about Alzheimer's. So I'm pretty sure that in a couple of years, part of the stigma will disappear. I always refer to the fact that in the 90s in Italy, we were not saying the word cancer. We were talking about the bad disease. Nobody was able to really speak about that. And the reason was because doctors were not able to describe what going through cancer meant. If you think today, we talk very openly about cancer. It's a word that inspires empathy, and that should be our goal as we talk about Alzheimer's. I want to thank all of you for this hour together. You were an awesome audience, but especially I want to thank this amazing panel, and thank you very much.
Now there's a 10-minute break, and then we'll move into concurrent sessions. One session in here in Pavilion Room will be Developing a Culture of Brain Health, the Case for Action and Adoption, moderated by Susan Spencer. The breakout in Hemisphere A will be